Assalamu alaikum and a very good evening. On behalf of Pakistan Society of Hematology Executive Council Committee, I welcome you all. So today's webinar is related to thalassemia, and we are very fortunate to have the eminent speaker, Dr. Farhan Ali Anjum, and the panelist. We all know the any introduction, and Dr. Khalilur Rahman is going to be the moderator for today's session. So I very warmly welcome you all to this webinar, and I hand over the stage to Dr. Khalilur Rahman. Thank you so much.
Thank you, Dr. Bushra. So I am Dr. Khalil Rahman, consultant clinical hematologist and bone marrow transplant physician at Pakistan Center of Hematology and Bone Marrow Transplant. I welcome you all to this 16th PSH webinar on the topic of management of thalassemia, standard of care versus resource limited setting. We are privileged to have been joined by Dr. Farhan Ali Anjum, who is speaker for today's talk. Sir is a consultant hematologist with more than 30 years experience in bone marrow transplant and cellular therapy, and sir is lead of gene therapy, adult gene therapy in UK. We have also been joined by panelist Major General Dr. Parvez Ahmed. Sir is head of bone marrow transplant and cellular therapy and at Pakistan Center of Hematology, Quaid-e-Azam International Hospital and Gambard Institute of Medical Sciences. So thank you, sir, for joining us. I will hand over the stage to Dr. Farhan Ali Anjum for his talk, and we will have a panel discussion at the end of presentation and question and answer session at the end of presentation. The participant can post their question in chat box or question and answer box, and we will discuss and have a question and session at the end of presentation.
Okay, thank you so much, Dr. Khalil, for kind introduction, and thank you so much, Dr. Bushra, Dr. Parvez, and all of PSH Society. I'm really privileged and honored. So I'm working in Manchester as a specialist in transplant and cellular therapy. I'm leading on gene therapy. So I don't have any disclosure for this meeting. This is the first slide. I just had done my disclosure. So this is the first slide, and it shows the two disorders of hemoglobinopathy. One is sickle cell, which is a qualitative defect. The other one is beta thalassemia, which is quantitative defect, leading to ineffective erythropoiesis. So why we really need a cure in thalassemia and sickle cell disease? Look at this UK data. The average age expectancy for male or female in UK compared to what sickle and thalassemia have. So it's drastically 30 to 40 years less. So this is an unmet need to do something about this group of patients. And on the top, look at when it comes to curative option of transplant. Because of allelic heterogeneity, there's 85% of chances difficulty in finding an HLA matched donor for sickle and 70% for thalassemia in UK because of number of siblings which are relatively 1 to 2. So that is a real challenge and leading to the curative options. What are the conventional supportive care? So you have blood transfusion, which has been traditionally being available for a long period of time with the caveat of iron overload leading to iron chelation therapy, which of course is in the form of either subcutaneous or IV desferal or desfereserox or deferipiron, which are in the form of oral tablet. But they have their own side effect. And of course, the cost is also an impact which affect that. Splenectomy is reserved for only few cases, only few centers do that, and it has its own demerits. What are the disease modifying treatment which has evolved in the recently? Previously, it has been seen the patient with persistent of fetal hemoglobin, they have less severe sickle and thalassemia. So that led us to use hydroxycarbamide and thalidomide as a hemoglobin F inducers. But that depends on how much hemoglobin is induced by these factors and the compliance of these patients to these treatment. Then recently there has been luspatercept, which affect on ineffective erythropoiesis and leading to high hemoglobin transfusion dependence, thalassemia, but cost is an issue, availability. And recently, there have been very good result of pyruvate kinase activator metabolite. This was published in ASH also and EBMT, that it affects seriously in these patients with thalassemia with a transfusion dependent. But remember, these are disease modifying treatment. They're not going to cure the patient. So the cost will be in fact. When it comes to curative options, all of the panel know that we have been using transplant with a caveat that is mainly used in children. If you look internationally, I think finding a patient of thalassemia above 30 years of age and having a transplant, the data is very little. So gene therapy, there are two gene therapy which are approved. One of them is Axicel, the other one is Peticel. So Peticel is used in US only and it's a vector based and it affects the beta globin gene. So you're replacing hemoglobin A, I mean, abnormal thalassemia patient to hemoglobin A. When it comes to Axicel, you're using CRISPR-Cas, which is clustered regularly interspaced palindromic repeat and Cas9 associated protein, very long name, and a tongue twister. So this enzyme, which is a bacterial enzyme used against viruses, is used to produce higher level of hemoglobin by knocking out BCL11A, which is B cell leukemia gene. And this uses CRISPR-Cas, and this is, remember that this is producing fetal hemoglobin, which is hemoglobin F. And that's very important to understand that one of the gene therapy, which is vector-based, is producing hemoglobin A by replacing a beta globin gene. The other one is producing hemoglobin F by knocking out BCL11. And remember that beta cell is only available in US only, but Axicel is available in Europe, Asia, especially Middle East and US also. Now, this is a very important summary slide of the cost of these treatments. Look at this transfusion and iron chelation. This is symptomatic treatment. People say that this is not costly, but in the long term, it has a cost associated with it because iron chelation tablets are costly. Then luspatercept, again, this is not curative, but it costs 80 to 150,000, and that is US dollars. To transplant for thalassemia is usually a myeloablative curative option, okay, and it costs in US around 100 to 300. In our country, it costs maybe around 200 to 150 to 200 thousand pound. Then comes to gene therapy, BT cell and Axicel. I can tell about the Axicel. It costs 1.5 million pound per patient in UK, and that's the cost of BT cell. Though most of the cost is taken up by the company because of production. So that is the summary of the options available. So you got transplant and you got a gene therapy as a curative option. But rest of everything is supportive treatment. But look at the cost of even the supportive treatment. If you continue for long term, so that's where the role of cost effectiveness come. Would you be like to continue a patient for 30 years with transfusion, iron chelation, luspatercept, or transplant that patient to save the cost? I think that's where it comes down to finding a most suitable option for a specific patient and kind of a personalized care, role of personalized care. Now, this is a very important slide and maybe take home message. Most of the time when we do an MDT, we are discussing only this in UK and US. We're discussing the cost of the treatment versus personalized care. Let's see if we have transplant. We have a lot of experience. I think all of us know that it's been available for almost 34, 50 years. We know how to do the transplant. We can manage complications. We know the long-term follow-up with the secondary malignancy, but it requires an HLA matched donor, the risk of GVHD, and the risk of graft failure. Gene therapy is a new kid in the block. There's no donor required, no immunosuppression, no GVHD, so far no risk of relapse, but it's a high cost, limited experience, and we don't know the long-term follow-up. So far, I think the maximum is 6.5 to 7 years follow-up of that gene therapy, but the longer-term follow is warranted for this one. The curative option for age in UK, we got sibling transplant and matched unrelated transplant, and gene therapy is recently approved in August. For adult, if you see, the transplant was just approved 2023 in November. Before that, adult sibling transplant was not approved. And gene therapy also came in 2024. So you'll be like to saying that the paradigm of adult transplant in thalassemia or curative option has just recently changed. I will spend a bit more time on gene therapy because we all know about the transplant with myeloablative therapy and disease modifying. We'll be spending more time on gene therapy and specifically on Axicel rather than BT cell because that's what we have currently been using in UK. So all of us before the age of 6 months were producing fetal hemoglobin. in the and that is where at 6 months the switch happens, and the switch happens because BCL11A cause a negative feedback and suppress fetal hemoglobin. That's very important to know that if you somehow can knock BCL11, the body has inborn ability to produce fetal hemoglobin. That's where hydroxy also works and thalidomide all act just to induce the fetal hemoglobin. But it matters how much higher hemoglobin F you can induce. So one-time infusion of axicell, which is CRISPR edited cells, can induce fetal hemoglobin as high as 90 to 95%. We know with hydroxy, we have seen maybe 30% in some fetal persistent hemoglobin, maybe 30 to 50%, but this can induce up to 90% of the cells. This is the trial which led to its approval. CLIMB 111 and 131. We can discuss more about thalassemia, but it was global multi-center phase 1, 2, 3 trial of gene therapy 12 to 35. And this is modern, that the age group was 12 to 35. I'm sure you know there is a trial going ahead for pediatric age 4 and above also currently by the same product. So primary endpoint was transfusion independence, secondary, of course, iron chelation, long-term effect. And for sickle cell, it was vaso-occlusive free. Age 12 to 35, beta node, beta node, beta node, beta node like, non-beta node, beta node. And if you see that the engraftment of neutrophil in the trial actually was 2 weeks later than what you see in the stem cell transplant. And also the platelet engraftment was 2 to 3 weeks longer. So I think that's one important step in monitoring and planning these patients. And this slide, let me just explain it to you. On the left side, you got a lot of black black. Each one of those black dot represent a blood transfusion of a thalassemia patient. Okay, and above is an adult patient and below is a pediatric patient. And then you see the gene therapy given in the middle. And then you see a bit of red spot. Those are the blood transfusion after the gene therapy required. And I think the rest of green area is all transfusion independence. You can clearly see there is 3 patients, 2 an adult, 1 pediatric, who after gene therapy required blood transfusion for a period of time. But I'm happy to tell you that the 2 patients and adult are transfusion independent and hemoglobin more than 9 for last 2 years now. And if you see the pediatric patient, which is the patient number 3 in the line, it has transfusion independence for 1.6 years, but hemoglobin is less than 9. So all the patients so far have been transfusion independent. But as per the trial criteria, because hemoglobin is less than 9, we still have 1 patient. So it comes down to 98%. And I'm sure all of us who are sitting here know that if you have 56 patients coming 3 to 4 weekly for blood transfusion, getting an iron chelation, if you give a therapy and you can only see maybe 1 patient out of those 56 ever coming back to blood transfusion, that's a huge impact on the facility, on the lab, and also on the quality of life of these patients. I'm being a transplanter. I've been doing transplant for more than 2 decades now. I think these are quite impressive results when it comes to curative option. And what about the iron chelation? That's another thing. That was secondary endpoint, but look at the amount of the hemoglobin, fetal hemoglobin, and also durable persistent of fetal hemoglobin in these ones. So it was not only hemoglobin, but also the fetal hemoglobin persisted. And then the side effect profile was okay as per the busulfan. Look at the neutrophil and platelet engraftment. It's very important to know because these patients need to be told that it's going to be 2 to 3 weeks delay for platelet and also 2 weeks for neutrophil. I will come back to our personal experience. When it comes to VOD, there were 7 patients who had VOD. 5 of them were pediatric, 2 of them are adult. So I think we all know the challenges in the pediatric, especially with the VOD. But there were more VOD cases in the pediatric age group in this trial. This is the current criteria, how we're using. One important line which I would like you to see is mandatory requirement to do genetic studies. I have no idea about the Pakistan, but I think in UK we were doing transplant, but we were not required to do a genetic study. If we have confirmation of sickle solubility test or transfusion dependent thalassemia, we can go ahead with the transplant. But now you need for gene therapy, because you're dealing with the genes, you don't know what will happen in the future. You need to have a genetic studies in the upfront to confirm what kind of a disease it has, how many alpha chain defects are there, and that's requirement of transfusion and pain crisis. I think easy to sort it out. And those centers who are developing CAR-T in Pakistan or anywhere else, I think they must be quite used to this slide that you need to have an accreditation, you need to develop a team, and then you need to develop an MGT where you can all sit together and discuss a patient, and a training of the staff and developing a pathway. Two other issues in UK are that some of the centers do not prepare chemotherapy in-house. They prepare outside facility and it brought in. Fortunately, why Manchester is leading in UK and also internationally in thalassemia is because we prepare of chemotherapy in-house, and we do have a lab to do the pharmacokinetic monitoring. And I think this was one thing which gave us an edge to lead the way in the UK and also internationally as a gene therapy thalassemia. And this is an also important slide for CAR T and gene therapy, that you use a portal which is developed by the company where you get training, you get put all the patients, their data, and they allocate the dates for collection, and they come in to help you run a dry run. They bring empty buckets, empty vials, and dummies to run through and explain to the staff that at the time when the apheresis or collection is done, nothing come as a surprise. So I think they're always there when you do the apheresis, when you do infusion, the one of the company representatives is always there, and that's very helpful if you have a doubt, and especially if you are new, because they have gone through a lot of centers, so they know the challenges if a new centers can develop. In UK, before the gene therapy, you can transplant a cancer patient. Like if I want to do transplant, I can discuss with my colleague as an MGT and go ahead with the chemotherapy and transplant. But for sickle and thalassemia, these are the steps I have to go. So the patient has to be discussed a local MDT, then a regional Northwest MDT, then a national MDT. And our national panel is 110 doctors, which include hemoglobinopathy, transplant specialists. And then is usually the role of a transplant specialist come in. And I think that really gives a very good consensus, because I do attend all these meetings. So before I even have seen the patient, I know the history of these patients. Remember, these patients have been following with one of the red cell consultant for years. So I need to develop a rapport. So these meetings just give me an idea of that thing. Briefly, I'm going to discuss these 6 steps, which is how I select a patient, how I collect cells, how I prepare it, how I give it, and then how we follow these patients. So first is eligibility and pre-mobilization. So it requires 8 weeks, and then mobilization is when we give some drugs to mobilize the stem cell collected, and then 6 months for manufacturing. I will come back to that, why we need 6 months, and then conditioning, which is an elephant in the room, busulfan. There's a lot of concern, a lot of questions, why we can't do triosulfan or anything else, why we need to do busulfan. We'll come to that also, and then post-transfer follow-up. So one by one, initial selection of the patient is done by hub and spoke model in a smaller centers who do blood transfusion. So we have a lot of written material and information sent to those centers. So when they see the patient in the clinic, they should ask question to themselves: is this patient eligible for any curative treatment? And that's the question I think we should ask each one of us should ask us also when we see a patient. Can we offer this patient any curative option? Even if cost is an issue, we should discuss with the patient that this is what is available, but these are the limitations. And then there are a few steps which we can do. We can do a genetic test. We can do confirm the diagnosis. We ask for sibling testing. And then it comes to the assessment of the liver, which of course in the current EBMT fibroscan role is coming up. But traditionally the gold standard, if in doubt, has been a liver biopsy. And then multidisciplinary team, like I told you, regional meeting, fertility discussion, and then the final confirmation. And this all done by the red cell consultant. Remember, this is not a transplanter who is doing that, but he is being kept informed because of those MDT. Now, what are the challenges? I told you the age is 12 to 35. What about less than 12? I think there are trials going. What about 35 and above? If a patient comes 36, 37, can I say no? Trial was for 12 to 35, but FDA, EMA, and NICE in the UK did not put an upper age limit. So I think that's where you need to discuss each patient fitness and other things. We currently are doing transplant up to the age of 40, which is myelability, but above 40, we are very carefully selecting. The genetic test, not all the centers will have genetic test. So currently Manchester is doing, Birmingham is doing, London is doing genetic tests for all the patients we referred. And remember, this is 5 million population, which currently Manchester is training it, which is all Northwest, excluding Scotland, and also the Northern Ireland. Fertility, Male fertility is easy, but female fertility, you need to have a surgical involvement with a gynecologist and egg collection. Then sibling typing. What one thing which I I have found out very helpful, that either in Pakistan or anywhere else, you need to develop an MDT where you ask the red cell consultant who are giving blood transfusion in the periphery to sit down in that meeting where you discuss the tissue typing. So when the tissue typing is happening, we discuss this is a thalassemia patient, which is in this region of the northwest, away from us like 50, 60 miles. Then we discuss remotely that, okay, what is the current status of this patient? What is sibling status? Okay, this patient is for sibling, mud, or a gene therapy. So in the meeting, before even seeing the patient, we can actually assign the patient to respective group at least. And then the liver assessment and iron overload and organ function, this is done by us. And like I told you, main important thing is that are you comfortable giving that patient hemoglobin F or hemoglobin A? It becomes very important for sickle cell, where if the patient had a stroke, are you comfortable giving a high hemoglobin F, or we still like to have a hemoglobin A? And alloimmunization, well, not so issue with the thalassemia, but I think this is an important step that you need to make sure that are you able to support that patient with the blood? And if there is HLA match requirement, are you able to sort this out? Two things which we have done after this we have done. We have involved hepatologists in our meeting and also neurosurgical team for the sickle cell and hepatologists to confirm, because I think those are the two issues when it comes to thalassemia, transplant or gene therapy is a VOD, which is a concern. So if you have in hepatology, can help you, and if it's a sickle cell, you need to have a neuro team to help us specifically about the moya disease or vascular challenges. This is a mobilization which we use currently in Manchester with GCSF, filgrastim, and plerixafor. We don't use motixafortide. US is using motixafortide. I would say that there are two protocols for plerixafor. One is a weight-based, and the other one is flat dose. After much discussion, we have convinced NHS England to give 20 milligram stat dose, which has helped us. The other important point to look at is the patient without a spleen, we have reduced the dose. This is our experience and it's unpublished, but it was presented as a poster in ASH and got award for best poster. I think this is our Manchester experience of adult patient. And we got so far 8 patients, 2 patients are not included in this one, but these are apheresis one. And look at the red arrow, this patient is 37 years age. Like I told you, this is outside the trial criteria. And to make it more worse, this patient had splenectomy. So look at the collection of this cell compared to the other one. You can clearly see that he struggled. And the other thing is, look at the white cells. It did go up, and that's a problem. Some might argue that why we're using reduced dose of GCSF in a patient who are a poor mobilizer. When you use GCSF in a patient with no spleen, it tend to cause very high white cell, and that can be an issue. So that's, I think, is the reason that you use reduced dose. This patient required actually 2 sessions to collect. Rest of all patient required 1 session. And this is pediatric data. Again, you see the CD34 correlate very well with the collection. And look at the last patient, which is a sickle cell. And I told you it's not the topic at this time, but this is a real challenge mobilizing sickle cell in a patient, in a sickle cell patient. So once we have discussed mobilization, we have mobilized the stem cell, then how we collect it. We need a line. We need a apheresis center to collect the cells. We usually for stem cells collect 1 day, but this one required 3 days. 2 days collection for the gene therapy product, which goes every day in the evening. And the third day is for rainy day. Like somebody asked me earlier, so far there has been almost 100 patients in gene therapy and sickle cell in the axis-cell trial, and maybe almost 50, 60 in the other trial. No patient had graft failure so far. The collected cells are shipped, and usually TDC require 1 session, but sickle cell require more than 4 session. For thalassemia, age more than 35, poor iron control, deferripiron, we all know the effect on the neutrophils, splenectomy patient, and CD34. I think this is very important that you need to check the CD34 post-plerixafor, and that goes with all the lymphoma myeloma. If that is low, the collection is poor. It requires 6 months because it uses CRISPR-Cas, and that usually takes 6 months for shipping and making it. And that time is used for fertility, job, if the patient is studying, to align with the studies and everything. To once you have product back, it can be stored for 2 years to plan the patient, and then it has to be. But we currently have a habit that we are infusing as quickly as we receive the product. So if you receive after 2 to 3 weeks, we align the patient. We keep the product with the company until we are 100% sure because of the issue with the of storing at our facility. Now come to the real elephant in the room, which is the busulfan. People have been arguing that this is a benign group of patients. Why we really need to have busulfan, knowing that it can cause VOD? Why we can't use triosulfan? I can tell you that there have been trials of triosulfan. It didn't work. There have been currently trial of anti-CD117, which is stem cell. Okay, that is going on. So if we can use that agent in the future, that will be quite helpful because it will be fertility sparing and risk of VOD. So people are working, but I think for the time being, we're stuck with this busulfan currently, and there's no way out of it. So for thalassemia, before the infusion, 8 weeks of hypertransfusion to suppress infective erythropoiesis. We make sure gene therapy product comes in. That role applies to CAR-T also. Myeloablative busulfan chemotherapy. There are two protocols of busulfan which were used in the trial. Trial did not say that one is better than the other. One is QDS, one is once a day. We'll discuss with the challenges of these two. And one important thing which is read that for transplant busulfan pharmacokinetic monitoring is advisable, but for this is mandatory. You cannot go ahead with the gene therapy unless you have busulfan pharmacokinetic monitoring. And the risk of VOD monitoring and early use of defibrotide. Remember the trial used prophylactic defibrotide in US and UK. We are not allowed currently to use prophylactic, and you can use GCSF after 21 days. Now, how we can decide which one to use, once a day or QDS? Age, I told you, pediatric group had more VOD, so should we use QDS in that group? Logistic, remember that if you're using QDS, there'll be almost 2 doses per day and total of maybe 8 to 10 doses which were given out of hour. How comfortable you are with your nursing staff and everything if you have a lot of chemotherapy given out of hours, especially busulfan with a short half-life, and it can expire, and there have been incidents. If you can check GST enzyme, because this enzyme is the one which actually metabolize, and the peak level, if you use once a day, maybe the peak will go higher, and the liver status. All I can say based on my experience, if you are using once a day because of logistic and anything, you need to make sure that you have a level before the second dose. And if you need to adjust the dose more than 30%, do not add the dose, add another day. So if you have 4 days, add another day after that rather than adding the dose. It will avoid the peak. This is our experience of once a day. And you can see that we are giving busulfan in the evening, and we are doing the levels in the night. So the levels come back around 10 o'clock morning, and the dose is at 5 o'clock. So we're just the second dose. This is the adult patient having a once a day level. This is the pediatric at same Manchester, which is using QDS. And again, you see there are 4 doses every day. The first dose is started around midday. So it's almost 3 doses which are given out of hour. And I'm telling you, this is a real challenge with the staffing, everything. You need to be really on the top of that because it has a short half-life. And if you're not on it, there's a chance that those can expire. Infusion, we do get these stem cells in a bag, right? But these one come in a vial, 5 to 6 vials. They need to be put in the water bath and then given one by one. And that's a real challenge. Last time we did it, the BBC was filming. So this put a lot of pressure on my nursing staff and me also being there because we had to put it in water bath, kept it, thaw it, and then give it within 20 minutes. So I think this is another thing. That's why dry runs were very helpful because the panic can set in between giving the vial, and it uses special adapters to give it. So I think those all few things were very, very helpful to know. We use currently refined EBMT criteria of probable for gene therapy. So we don't rely on Baltimore or Seattle. If we have probable criteria EBMT, which is bilirubin, hepatomegaly, weight gain ascites, any one, 2 of them, we start defibrotide. And I think that's the message I want to get across, that earlier signs of VOD, you start defibrotide if you can. I know the cost is an issue, but I think it's cost effective in a patient who has established a VOD. Of course, these patients are being kept on ursodeoxycholic acid. So early use of defibrotide is the main thing. And fluid, we twice a day weight and monitoring of bilirubin. Now, this is an evolving thing. What to do after the post-gene therapy? I'm being honest with you. Nobody actually know. They have been using most of the things which the trial did. But I personally think there's a lot of things which might not be required in the near future. Acyclovir for 1 year. This is auto transplant. CMV, do we need to really check it? But This is edited stem cells. This is not exactly just auto transplant, and this is not an allo. This is right in between. So I think there is a lot of this thing which hopefully gonna change. Vaccination at 6 months, monitor hemoglobin F and hemoglobin, and prefer to avoid oral chelation. Start venesection around 4 to 6 months and monitor ferritin. Continue follow up with the red cell team. That's very important. Do not let the red cell team lose the grip of the patient, because those are the team who have been involved. So let them manage the chronic pain of sickle cell. Let them manage previous osteonecrosis, pulmonary hypertension, other, because it's a comprehensive care, and thalassemia, pituitary, endocrine problem, previous osteoporosis, and previous iron overload. So let all the teams involved, because there's potential that once you see, okay, gene therapy and transplant done, all the teams would not be following the patient. So there's a chance that there might be, it's a cure of one problem, not the previous problem. So chronic pain, and one important thing is that these patients should remain in a long-term study, which is called PAUSE. Iron chelation. Once the patient is engrafted, you need to monitor it for 3 months stable hemoglobin. If hemoglobin is stable more than 3 months, which might be 4 to 6 months, you start phlebotomy with the aim to bring down ferritin to less than 500. But you really don't need to press very hard on this one. Remember that these patients will be quite fragile of this myeloablative. So go slowly. What I'm currently doing is starting around 6 months, give them lump time, 5 to 6 months, and then trying to do a venesection 4 to 6 weekly rather than 4 weekly, and monitor the ferritin. And you need to have a ferry scan and cardiac T2 at 1 year at least for a couple of years. This is something which we are developing. I told you that no transplant gene therapy was available for adult, but you got a lot of leukemia societies, even in Pakistan and here, to help cancer patients, but nothing available for hemoglobinopathy or benign patient who get a transplant. We don't have societies or community support for these patients. In the future, I think there will be a lot of patients who had transplant, but we don't know how to help them psychologically, socially, and otherwise. So I think this is an unmet need where the nation has to come, the societies have to come to help these patients psychologically, socially, and monitoring. Currently, these patients don't have their own long-term clinic, so they're falling in the CAR T clinic. I don't know, is this something which you guys can think of, that where these patients gonna go off? Because I'm sure the transplant patients are being followed in the transplant after that. This is the first real world gene therapy of thalassemia in the UK, which was delivered in Manchester. 29 years male, PhD student, thalassemia, Q4 weekly blood transfusion. He was getting deferricerox. We got a liver iron of 3 gram, cardiac 32 millisecond. We mobilized him with GCSF and Prolixo4, collected 38 million. Now you might wonder why we needed that cells. 6 months period, but look at this actual product, which was 7.6. So where are all the cells lost? The CRISPR-Cas uses electroporation. This is electric current to pass CRISPR-Cas into the cell. So almost 40 to 50% of the cells are lost. And that's very important, that you need to collect, because after one collection, we got 20 million, and somebody called me from the stem cell lab, do we need a second day? And I said, yes. So send all the cells which you're needing, because there'll be a lot of ineffective erythropoiesis cells or nucleated cells, which the machine might be difficult to separate. This patient had no VOD and grafted very early compared to the trial, platelet 31, and he was actually discharged after neutrophil engraftment on day 25, compared to almost 35 to 45 days in the trial. Currently, this patient is 1 year. Hemoglobin is 154, hemoglobin F is 93, and is falling in the later fat clinic, and is enrolled in the trial. This is the parameter. If you can see, after 1 month, no platelet blood transfusion, and hemoglobin F is rising. Transfusion requirement none, and this is the ferritin. Is currently reaching 1,000. It was 2,500. So first time in his life, he actually was. He told me that he's transfusion free, and he's off iron chelation, and that has impacted him huge. Remember, he's a PhD student. He wants to get married. He had a fertility sperm banking. So now he told me that, Farhan, I now don't need to think about this cross match and every 2 to 3 week appointment. I can go anywhere and I can do the job which I wanted. This is the experience of Manchester. We got 26 patients, 15 apheres, 6 infused, and we got 29 patients of liver assessment. What are the future challenges? Genetic studies, fertility, what to do about age, community support, psychological support. There's something called off-target editing. That this is a CRISPR cas. This can edit at multiple points. In the trial, did not happen, but off-trial, 2 patients had editing at the urea cycles. They're monitoring those patients. Nothing happened, but I think this is maybe an alarm signal that these patients, like somebody mentioned, that these patients need to be followed. And then you can send all this product, but the company won't be able to edit the cell. This happened to 1 patient. And of course, sickle cell patient with stroke, delayed hemolysis, difficulty in finding blood, poor mobilization is a real nightmare. For thalassemia, if you can monitor and plan the patient from the VOD side, I think gene therapy can be potentially curative for almost 98% of the patients. Take home message, it is important that when you see a next patient in the clinic, ask the patient or yourself, is there any curative option available anywhere which we can discuss? Regardless of the cause, I think patient has a right to know that there is something available, but these are the limitations. I think it is his right to know that something is available, but it's not something which we can do. I know someone who had this idea and then talked to me and then went on a job to Gulf and had a gene therapy in Bahrain from Pakistan. So just word of the word of thought that if you discuss with the patient, they can find a way. Transplant remain a widely option, but gene therapy has the potential to expand, though costs remain a limitation. Centers should explore eligibility of trial, especially those who have can do CAR T. I think they can be enrolled in the gene therapy trial. Sharing experience across the globe or regional challenges and solution can help a vital role. This is my team, which include Red Cell, my specialist nurses, pediatric team, and as I told you, I drain all Northwest and Belfast, Northern Ireland, which is almost 5.2 million. So it's a huge area to drain, and quite a lot of patients coming in for these curative treatment. It's a privilege to actually deliver. So I'm ready for any questions, and thank you so much.
Sir, thank you so much for the very enlightening presentation. Sir, I just wanted to ask that how far are we in Pakistan from establishing a gene therapy? I mean, in the logistics and finances, and how rapid can we expect the cost to come down?
Actually, you know that initially when you have any product or any drug, there's almost 2 to 3 years of this period when the company is not letting the price to go down. But there are competitors coming in, like BT Cell is currently in the USA, and there are some products coming from China also. So I think I'm 100% sure that if we all keep an eye on ASH and other major studies, you can see that the price will definitely go in. More worry is setup. We really need to have accreditation to develop a capacity and competency to deliver at least CAR T therapy. If you can deliver CAR T therapy in a center, then I think gene therapy is much easier. Remember, this is an auto cells which are edited by a company, and we know, I think all of us know how to manage a busulfan. It's a CAR T which is neurotoxicity and CRS, which is of course a totally different paradigm. So I think the first step in Pakistan will be to try to get a competency to get a CAR T, because currently when they came in to most of the UK centers, they first found out that is the transplant center able to do the CAR T therapy, chimeric antigen, and has a JC accreditation for that one. And then they found out, then they accredited us to. I think maybe this is the one, but I'm 100% sure, Khalid, the price will come down. Price, I think, will not be an issue because there are a lot of companies which are putting the money in it, and hopefully it should come down.
Thank you so much, sir. Now I would like to invite Dr. Parvez Ahmed to share his experience in resource limited setting, and also give you an update on CAR T cell therapy in Pakistan.
Thank you, Khalil. Thank you very much, Dr. Anjum, for excellent talk and very enlightening and very encouraging to know that there are curative therapies option available for patients who are otherwise not eligible for bone marrow transplant. Currently, there are 2 centers in Pakistan that are developing this facility of CAR T cell therapy. One is at Armed Forces Bone Marrow Transplant Center, that is one of the biggest and the most advanced center in Pakistan. And the second one is in the interior of Sindh, that is a center at Gambut, a small town I would say, but The hospital is quite big, and they are doing a lot of transplants there: liver, kidney, the corneal and bone marrow transplants. And hopefully by end of this year, both of these centers they'll start the CAR-T programs.
Dr. Can I ask Dr. Parvez, is there a chance, because currently Manchester has 4 products available, and there is a new product which is called Autolus, which is of course different from other product, and we were delivered in Manchester. And initial trial of some of the products were also delivered, started in Manchester. If there is any chance that we can help put up SOP help in Pakistan centers who are trying to get onto that path. I'm sure they are in touch with other centers also. But if there is any chance that we can help from Manchester, helping them in SOP pathways or training, or even asking somebody like a fellow to be trained for a couple of years or maybe 1 year, is there a chance capacity for to do that?
Thank you very much. That's very generous offer. And our main, I think, the weakness is the lab component. If we can get training, HR training in the lab aspect of the gene therapy, the cellular therapies, would it be? I mean, that would be a great help for all of us.
Okay. Are you
Because
talking about the stem cell labs, Dr. Parvez?
yes, stem cell lab and the cellular therapy lab.
Okay. If it's okay, I can talk to of my stem cell lab director. We can set up a Zoom meeting, and maybe that will be if that helps
Yeah, yeah.
at
I think that's a great offer, and that should be very helpful. And if possible, to arrange maybe short training, sort of even just observership of 4 to 6 weeks at your stem cell lab for our HR, so that they can see the protocols, they can see the procedures with their own eyes before actually physically doing these. That will be quite helpful for all of us.
Okay. Because we got one, I think, person coming from Bangalore, India, and then 2 coming from India, Sri Lanka, Colombo, for specifically this. So that's why I'm saying, because Manchester is training the staffs in CAR-T and gene therapy. So that was the reason I was saying that, because I didn't see anyone from Pakistan approaching. So thanks for letting me know that there are 2 centers working on it.
Sir, we have some more questions in the question answer
Yeah.
box. The first question is from Kiran Amir. What are the challenges and solutions for implementing bone marrow transplantation and gene therapy in Pakistan?
A good question. I think if you're talking about the adult patient thalassemia, that's a real cliffhanger because of limited data, extramedullary hematopoiesis. You need to have a pre-conditioning with azathioprine and hydroxyurea to suppress the disease, risk of graft failure. All what I can tell you that in UK, we are pressing very hard that for adult thalassemia patient, gene therapy should be the first option despite the availability of a donor, because we personally think that that will be cost effective considering the risk of graft failure, VOD, and this problem with the transplant, including the GVHD. So that's one short answer for this one. But sickle is bit broader answer because sickle has this non-malleability TBI and campath conditioning, which is very, very less toxic, very easy to deliver. We are delivering it at an outpatient. So I don't know whether is this something which Pakistan is doing, because that suits Pakistan, because this has like a 4-grade TBI with a campath. I know campath is not available, but something we can, it's just a T cell depletion which is needed with a bit of TBI for sickle cell. For younger patient, I think there is in pediatric age, there is a myeloablative fluid rheotherapy power busulfan kind of a conditioning, or even reduced one. So for sickle it's a bit different option, but for thalassemia transplant, it is difficult in adult, specifically because of lack of data and as with the challenges of graft failure and other thing. But for pediatric, I think there is a good data that for pediatric younger age, and I think future will be that all the sickle and thalassemia patients will have one of the curative option, either transplant or gene therapy while young, so they don't go through those all complications. So I think in Pakistan, the challenges will be to develop these pathways and a system where you have a collaboration of a centers who is doing a transplants with the other centers and learning from experience, because that's what we have done. We have recently changed reduced intensity conditioning for sickle cell from myeloablative to reduced intensity because of the extra toxicity. And for adult, we are sticking to TBI campath, which is outpatients. Imagine the patient goes for TBI campath and then stays close to the hospital within 1 hour, and that is cost effective in a country, even in a country like Pakistan. For thalassemia, I think that for adult is a challenge, and I think that we will find out in the near future. But I think above 30 is the real challenge.
Thank you, sir. Sir, there is a question related to the same topic, that
Hmm.
why children below 12 years are not candidate for gene therapy, from Dr. Marine Ali Khan. And ma'am
Hmm.
is also paying special thanks, and has an update that we are almost ready for CAR T cell therapy at FBMTC.
Oh, thank you so much for answer and good luck. It's good to hear that. You feel proud if you hear that some centers in Pakistan are doing CAR T. And okay, it's I think that when they do the trial of anything which is 1.5 million pound or one to 2 million US dollar, they really want a good result. So they really selected a group of patients where they thought will be a less problem. Less than 12, there is more risk of VOD, and more than 35, you tend to develop more comorbidity with pulmonary hypertension and sickle cell, stroke, and multi-organ problems, nephropathy, and thalassemia, pituitary endocrine problem, and liver iron overload. So I think they selected this group of patients specifically to see that safest group of patient. But I can tell you that there is trial going on in a pediatric age group 4 and above, and Manchester is included, and we got patients enrolled to that one. And I think abstract was presented at ASH also, this very impressive result. And like I told you, in the near future, all the patients in UK and in developed countries and underdeveloped country also will have an option for a curative option in pediatric age group, because it makes sense to get rid of this condition in pediatric age group so you don't develop all those complications. But great question.
Thank you, sir. Sir, there is another question from Dr. Saeed Zaidi. Please throw some more light on possibility of off-target gene editing and its effects.
Hmm. Thank you, Dr. Zadi. All what I can say that we are in touch with the company, because I think there are few things which are still not totally out of all the data of those two patients who had off-target editing. In the trial, there were 100 patients. None of them has off-target editing. But the real world poses a different challenge than the trial. And this is exactly what I was telling. You really select a group of patients for the trial, but in the real world, you can't select a patient with all this problem. You need to take it. So I think it was a urea cycle. All what I can tell you, it did not affect hemoglobin F or any function. It did not affect any of the metabolic problem. There is very extended panel, like whole gene sequencing and monitoring of that patient. And all what I can say, that the long term of these patients, that's why every patient who has gene therapy, I think it's very vital that they remain on a past study, because that study is sponsored and funded by the company. So these patients will be followed for the period of 30 years. Okay, and it will be good to see the data that how many patients had off-target editing and how many of those off-target edited patients had any of the long-term complication like leukemogenesis, because you remember that there was a Bluebird Bio company who initially produced gene therapy, and two of the patients developed AML. So I think maybe this is what you are referring to. So I share your concern, but currently those patients are monitored, because I think this happened just in the last year.
Thank you, sir. Sir, there are two more questions regarding the gene product. The first one is what exactly is meant by gene product available before admission, and second one is that can we export gene product from UK to Pakistan?
Yeah. Regarding the first question, uh, you know when you develop a cellular therapy like a CAR T or gene therapy, there can be so many things which can go wrong. Some company can tell you that the product is ready, and then the final quality check or transport or anything can have a delay. So I think just to take that thing out of the equation, you get the product in your center, you get a delivery report, and then you get a proper black and white confirmation from the stem cell lab that the product is available in house and cryopreserved. Then only you are allowed, as per regulation anywhere in the world, to start conditioning. And that, I think, is a patient safety issue because of the current issues. Because I think you remember recently there has been COVID and other wars and other issues. These products are prepared anywhere else. So if you have one of these situation and you start patient on conditioning and the product can't come, that would be hazardous. So I think just to take that thing out of equation, that is regarding the second questions. Currently there is a regulation that if you have collected a cells, it has to be given at the same place, so you can't transport the product. But if you have a patient collected in Pakistan, because UK is producing CAR-T product, and I think a couple of other centers are also. So if you send us here to manufacture, then it can go back to Pakistan once we have those accreditation and SOPs and pathway and agreement between the countries. So I think that is doable as long as you collect it, send it to us, and we manufacture it and send it back to you so you can prepare. Because I think currently it's Netherlands, UK, and US which are in the process of manufacturing.
Thank you, sir. There is another question for Dr. Parvez. Can we introduce a 6-month training post-clinical hematology fellowship to get observership for gene therapy in UK through an MOU?
We will welcome and we will wish that we are able to do that, but we are at the receiving end. Maybe Dr. Farhan Anjum can throw some light on it, whether
Okay.
there is possibility of offering 6
Okay.
months observership.
I think we have a MTI program, which we call. We have a couple of persons coming from Sri Lanka, a couple from India. We currently have 3 from Pakistan, and I think one of them is currently doing work with me in the gene therapy, and he's from Pakistan. I think we all know him. So I think yes, it is doable, but I think maybe 6 months will be too less time to go through all the things which are pertaining to gene therapy. I think minimum of 1 year might be a helpful for those, but this is something which we can definitely discuss.
Thank you, sir. Sir, as we are running short of time, there are two quick questions. What is incidence
Yeah.
of BUD in your cohort, and any role of also deoxycholic acid routinely? And second question is, are there any infrastructure challenges considering high cost? How can we select patients in low resource settings?
Good question. Regarding ursodeoxycholic acid, all patients who get transplant, all patients who get gene therapy, all patients who get CAR-T, they are started on ursodeoxycholic acid. I have no idea how much benefit in a specific situation it does, but this is something which we have agreed as a unit and also as a nation in UK and US also, so to use that for all the group of patients, at least for 1 year leading to the post transplant. But despite that, the VOD does happen based on patient factors, which are like I mentioned, liver status, iron overload, and those things. We can use defibrotide here. I know the cost can be an issue in certain countries, especially in Pakistan also for adult because of this one. In our cohort, we had 6 patients so far infused, 3 pediatric, 3 adult. We got 1 patient with a VOD, which resolved with defibrotide, and all of our patient was discharged less than 30 days home. So thankfully, touch wood, alhamdulillah, so far there hasn't been any serious problems with that. And even in the trial, there were 7 patients with a VD, but all resolved. So it seems like, I think in adult patient, if I may say, that it will happen in few patients, but if you early start defibrotide, you can save the patient. And another thing is you need to make sure that you have a lab with you, because some of these patients might require HLA platelet also. So I think those are the factor. If you are not able to keep platelet more than 20, 30, and if you're not able to initiate defibrotide, I think that will be a real problem. But if you can do that, most of these patients resolve, as we have seen in the real world and the trial.
Thank you, sir. Sir, we have run out of time, but if you allow, can we take 2 more questions in the?
I am all okay with that, sir.
So the first question is from Dr. Uzair. In patients with multiple transfusion and iron overload, does that affect eligibility or outcome of gene therapy as it does in bone marrow transplant?
Good question, Uzair. I hope you're okay. It's not the transfusion overload itself. I mean, all these patients will get, the longer they get, because one of the patient currently who is going through the gene therapy is 39 years old. So inshallah, hopefully you'll be okay. It's the iron overload in the liver iron content and a historical compliance. Imagine, I give you one example. We got 2 patients who had a liver iron content of like 18 to 20 gram per dry weight for a couple of years because of poor compliance, and then it remains around 3 or 3.5. The fibroscan was okay, everything was normal, but I did go ahead with liver biopsy. Why? Because if you have a liver iron remaining high for a couple of years, there's a chance that you might induce some fibrosis. Even if you reduce it down, that injury might have been happened. So surprisingly, when we did a liver biopsy, what was the score? It was 3. So it has already established stage 3 fibrosis. Imagine that if you give a busulfan to this patient, BOD will be definitely happening. It has 70 to 80% mortality. So you might say that you might have excluded that patient from gene therapy, but in other way, you might have saved his life. Maybe something else, like there's a trial coming in Manchester using anti-CD117 instead of busulfan, and that therapy is potentially less toxic. So maybe that suits this patient better than the busulfan. So I think the short answer is it's not the transfusion overload, it's a liver iron content, the liver status on a fibroscan, and the liver biopsy which decide that how the patient will behave or have BOD. I hope I answered your question, Azhar.
Thank you, sir. Sir, there is another question from Dr. Marine Ali Khan. In Pakistan, where there are more than 1 lakh beta thalassemia major patients, can we plan gene therapy in milk-related children not having full HLMH sibling due to the lack of mod registry in Pakistan?
Very good question, because in our national panel, we got a very heated debates, because I'm a gene therapy specialist and I'm leading. So I'm an advocate of my patient. If I see a mud transplant with this GVHD and other risk, I advocate to go with the gene therapy. I mean, off the record, gene therapy can be offered if you have a donor, but somehow you can make sure that the donor is either unavailable or is not willing. So sometime we discuss with the family and take their concerns, okay, and let them decide that these are the 2 options, okay, because potentially we can't push them on one side. But being an advocate of the patient, I can see what you're saying, Mahreen, that in a specific group of patient where you can see that the transplant will be toxic to these patients, irrespective of the cost. I think you can be advocate of the patient that you can say that ideally it should be gene therapy if provided it's been given. So I think in a thalassemia group of patient with all the conditioning and everything, I think it will be fair to say that if the gene therapy is the most safest option currently, with 98% of the time that you can get transfusion independence and off chelation with no graft failure and with no graft host disease, no risk of immunosuppression. Okay, because there have been quite a lot of problem with our thalassemia patient. Risk of secondary malignancy a bit more with the transplant somehow because of the conditioning. We'll see what is the effect of what is the secondary malignancy or other risk in the gene therapy now. But at least short follow-up of 7 years, we haven't had any risk of malignancy in this group of patients.
Sir, we have one last question from Dr. Salma Amir. Given the challenges with patient compliance and follow-up in Pakistan, especially in Peshawar, what strategies have proven effective in improving adherence to transfusion schedule and iron chelation?
This is my favorite thing. I think currently the compliance is is, I think you cannot blame the patient. I will just tell you one example. We got one patient who had a transplant and we were really struggling to get him across. We got him a smartwatch and we connected to one of the app. So we monitor his vitals and everything for a couple of months and then monitor him like a virtual ward. You can develop a virtual meeting. You can ask a local doctor to have an eye on them in a group of patients where the compliance is here. And I think that's where the networking work. Like you need to find in a selected area, like in Peshawar or certain areas, Swat, Mardan, Swabi, or where the patients are coming. You need to find a physician you can develop a rapport with him who is referring the patient and then take a help from them to follow up the patient if the patient cannot come in. Because remember, these patients post gene therapy or transplant is an immunosuppression, but post gene therapy, all you need is a hemoglobin level, okay, and then making sure they're fine, or ferritin. With the gene therapy, it becomes real problem of immunosuppression monitoring if they are on immunosuppression. So I think, but what we have done here, because we are draining quite a big area, we have developed the hub and spoke model. So Manchester take care of the patient, but ultimately then refer back and then keep them on their radar with a remote telephone consultation just to make sure that things are okay and sending the reports. They have group, they have WhatsApp group, they have other groups. So there is a lot of this social media or others app which you can develop to help these patients. And the patient, you'll be surprised that the patients are actually better in using WhatsApp. And actually my son is better than using WhatsApp and all these things than me. So I think this new generation, you'll be surprised that how good they are when it comes to monitoring these to using these tools to remotely monitor these patients.
Thank you so much, sir. Thank you, Dr. Farhan and Dr. Parvez, for joining us today.
Great talk.
Thank you so much, Dr. Parvez, Dr. Bushra, Dr. Aisha, Khalil. Thank you so much for all
You,
the
sir.
help you did. So it was really honor, privilege, and to get back to talk to first of all, and to see you. And I'm looking forward to have more collaboration with you guys. So just remember that you've got a friend in Manchester. Give me a shout, and I will be there for any meeting or any collaboration.
Thank you so
Thank you
much.
so
Thank
much,
you
sir.
so
Thank you.
much. Thank
Okay.
you. Thank you so
Okay.
much. Good night,
Thank
sir.
you
Bye-bye.
so much.
Bye-bye.
Love this. Love this.
Lafis.
Thank you, sir.
थैंक यू जी गुड शो बड़ा ज़बरदस्त रहा है ये वेरी
जी
वेल
सर
अटेंडेड
थैंक यू सर
गुड इनिशिएटिव